with the different portions of the large bowel. Make sure you do, because when we talk disease processes and when we talk testing, certain tests only look at certain parts of the large bowel. Colonoscopy is different from a sigmoidoscopy, which we talked briefly on, but we're going to talk more specifics for certain diagnoses that we want to do a CT or a flex sig or just an anoscope or a colonoscopy. And you kind of have to understand the anatomy to know why one imaging modality would be better than the other. So if you're not familiar, it's pretty straightforward, but make sure you look at the different portions of the intestine, because we're going to talk about where processes take place in the intestine matter, and then how we test it matters, because you have to use something that can actually see that portion of the large bowel. If you're worried about ascending colon and you say, I'm going to look for the flex sig, well, you're about a mile away. We'll talk about that as we move forward. Same concept as last block. We're just talking, remember to think anatomy, what's going on in the area that the patient has a complaint. So there are several diagnostic tools. I just mentioned a few. The ones we're going to talk specifically, that air contrast barium enema, that's kind of old school. It came out in like the 70s. I think the next slide shows one, but basically it's an enema. It's a tube that goes up, and the tip, they put contrast in, and then they use air to force that contrast up in through the bowel, and then any excess of the contrast material, the barium, leaks back into a bag. So it's been around for a while. Flex sig, that's what we're going to look at. Basically, just from the anus, rectum, up over about a third of the way up the descending colon, and then the colonoscopy is going to get everything. It's from the tip to the bottom in reverse, right? You go in the anus, you can see everything from the rectum all the way over to the cecum where the appendix is with a colonoscopy. We'll touch briefly on a barium enema, the same concept as the barium swallow, except for you're not swallowing, it's being put in there. And then the gold standard is always the colonoscopy. For direct visualization of the colon, it's colonoscopy. And then folks that can't, for whatever reason, or refuse to get a colonoscopy, the bowel prep is a big reason, because you have to take some of those laxatives to completely flush your system. Go lightly, is the name that we often use, but you drink it, and out everything goes, and then you're clear to go get your colonoscopy. Hard to get compliance with it. It's not fun to walk around for half a day not eating and having a whole bunch of abdominal cramping. So if your patient refuses or doesn't prep properly, or for some other reason, we can go into a newer imaging study called a virtual colonoscopy, which is a CT colonography. So I think the next couple of slides just a little bit more in depth than what I just discussed. There's the barium enema with a little more background to it, but basically the tip goes in, the barium goes up, air pushes the barium throughout the large intestine. And there's what it looks like on imaging after you've had the barium enema. Or we can call it dual contrast, because there's air and barium in it. Like I said, older technology. Flex sig, well, you can see where the tip gets up to, right at that flexure, and kind of shows the end of the apparatus and the camera there. Examines the rectum and the distal colon. Less invasive than a colonoscopy. You don't have to do as much of a bowel prep, but once again, colonoscopy is gold standard for direct visualization of the entire bowel, because you can see it only gets up to the top of the descending colon. So colonoscopy usually preferred for most diagnostic evaluations. But if it's something that's lower in that large intestine, and if we think it's somewhere from descending colon down through all the way to the rectum, then we can use the flex sig. There's just a little bit a visual of the colonoscopy, and some things on the right, some things we can pick up with it. But the gold standard, because as you can see, with the green line on the slide on your left, that's where your flex sig pretty much looks at, and then the colonoscopy is the green plus all the yellow, all the way over to the C. CT colonography, a virtual colonoscopy, right? This is where we can't do a colonoscopy for some reason, or patient fails a colonoscopy. In other words, we can't get the pictures for whatever reason. Or if there's an obstruction that you can't actually push the colonoscopy or the colonoscopy apparatus, the camera, or the flex sig up past an obstruction, we might have to do a CT colonoscopy to look at, I guess, upstream from the blockage. If we can't get the flex sig or the colonoscopy to up past an obstruction. And then if they just flat out refuse, and you want to be nice and they still need the test, or they're of a certain age or have a high genetic risk, then we can get a CT colonography. And there's just an example of the CT scanner and what that colonography looks like. And once again, just showing when we do the full colonoscopy, what you're seeing. Other studies, we talked about the anoscope. Mainly these three tools, the rigid sigmoid scope, so obviously that's going up a little higher to the large intestine than just the anoscope. But mostly these are anorectal pathologies, the ones that you just passed, that you had information on, the hemorrhoids, the fissures, and the rectal masses. So now we're going to talk about three main issues with the colon itself. That Clostridioides difficile infection. I'm sure you've heard numerous times already in your training. So C. diff, CDI, Clostridioides difficile infection, which can lead to a pseudomembranous colitis. We're going to get a little deeper into diverticular disease and talk about the difference between diverticulosis and diverticulitis. And then obstructive processes and motility disorders, just like we discussed with small intestine lecture. Each one of those is going to have a different pathophysiology, a different presentation, and a different treatment. So antibiotic-associated colitis is not CDI. It is not Clostridium difficile infection. Patients often get a little mild diarrhea, self-limiting from antibiotics. Simple antibiotic-associated diarrhea occurs because antibiotics work in that gut microbe, right? But that's usually mild, self-resolved, gives them fluids, But true colitis from C. diff, CDI, Clostridium difficile infection is a true colitis, and we're talking about the differences, right? But just antibiotic-associated diarrhea does not equal CDI. It's routine diarrhea from an antibiotic. And then we'll talk about what sets that apart from CDI. So a true colitis, or a true infection of the colon, is usually CDI, usually Clostridioides difficile. Who's at risk? Your patients are in the hospital. Major cause of diarrhea in patients who are hospitalized. About anything 3 days or more, high risk. About 21% of patients that are in the hospital for more than 3 days are going to develop CDI. Like I said, the I is infection. So the symptoms can be mild even with CDI, but we can have fulminant disease that goes from that mild disease, and then we'll talk about the next phase when you get that pseudomembrane, and then ultimately CDI can lead to fulminant disease, which is a toxic megacolon, which we'll discuss. So what is C. diff? Clostridioides difficile, spore-forming anaerobic bacterium, and it produces a toxin A and a toxin B. What the toxins are going to damage the mucosa of the colon, which causes inflammation. And how do we get it? Well, fecal oral, and then also contaminated surfaces. The spores that are formed by C. diff can hang around a long time. So up to 5 months, I think it says on your slide there. So we have to use good hygiene and good cleaning practices. Because we can get it from other folks in the hospital, or your patients that are in for 3 days or more can get it from contaminated equipment or contaminated surfaces. Biggest risk factor is antibiotic exposure. Common ones that can cause C. diff: Clinda, the fluoroclinolones, 3rd generation cephs, and ampicillin. But almost any antibiotic can cause C. diff. Almost any antibiotic can. Those are just your big players. Ampicillin, Clinda, 3rd generation cephs, and the fluoroclinolones. And the next slide, I think, is an actual chart showing you, so frequently associated, occasionally, rarely, but you can pretty much, in the rarely, you can put every antibiotic that's given for anything ever, because every antibiotic can. So your big players, they're on the far left, in a nice chart that calls frequent CDI. There's some guidelines if you want to learn more about it. Click on the link. That's from the American College of Gastroenterology. And that's their CPGs, their clinical practice guidelines. What the American College of Gastroenterology says you should do when you encounter a patient that you think has or has CDI. Signs and symptoms: watery diarrhea, very foul smelling stools. So foul smelling sometimes we associate with those malabsorption type diarrheas, but here it's watery with abdominal cramping and mild leukocytosis. May have a little mucus in the blood. In the stool. So diagnosis requires 3 or more unformed stools within 24 hours and positive testing. So we're going to talk about the testing algorithm here in just a second. And it also gives you your serum creatinine less than 1.5, and leukocytosis on the CBC is less than 15,000, so it's mild. Severe disease, now we're starting to get the systemic presentations. Fever, abdominal distension, severe leukocytosis. Now we're above 15,000 on the CBC. Serum creatinine is greater than 1.5, and you also start to lose some of your protein, so your hyperalbuminemia, less than 2.5 grams per deciliter. Serum lactate will also be elevated if you draw it. So if they have these severe signs and symptoms, now we're going to have to do some aggressive treatment, and they probably, and we'll talk about the specific kind of protocols for why they would need to be admitted. Fulminant disease. Now we're talking shock. So we went from mild diarrhea, then we started having some systemic issues, some changes on our blood work, and some lactate positive, a little and then worsening of the leukocytosis, and now we've got fulminant disease. Shock, ileus. What's ileus? From last block? It's not moving, right? It's immobile, which can lead to toxic megacolon. And this is emergency management and surgical consultation because we can get multi-organ system failure from the fulminant disease from CDI if it goes untreated. So once we get fulminant, we got some shock. Multi-system organ failure is right behind it. We get the diarrhea kind of stops because once we get the ileus, nothing's moving through the large bowel. And then it can lead down to megacolon. And that's severe toxicity. And then we're going to talk about what you see on radiographic findings is a large bowel was dilated greater than 6 centimeters. That's an important number to know. And then, or greater than 12 centimeters in the cecum. So I know those megacolon measurements. Pseudomembranous colitis. Severe inflammation can produce pseudomembranes on the colon mucosa. You'll see them there in the picture. They're yellow plaques, and obviously you're going to have to do a colonoscopy to see them on the colon. So pseudomembranous colitis, this is severe inflammation causes this on the colon, and then on the mucosa of the colon from CDI, and then you'll see it with the colonoscopy. Raised yellow or off-white plaques, 2 to 10 millimeters in diameter, all over the colonic mucosa, caused by CDI. Here is your algorithm for diagnostics, but usually it's 2 steps for testing. We're going to talk about what exactly the acronyms mean on the next slide, but your 2 steps testing strategy usually is the antigen testing for GDH and then a toxin assay. And then NAT testing may be used for indeterminate. If you follow that all the way down, so if your patient has unexplained and new onset diarrhea with greater than 3 unformed stools in 24 hours, and especially if they're hospitalized more than 3 days, then we're going to start with our 2 steps. Antigen for GDH, and then a toxin assay. And if we have indeterminate, from our first 2 steps, we can do a test called the NAAT or NOT. Initial test is the enzyme immunoassay for C. diff glutamate dehydrogenase. That's GDH. So that test is going to use some antibodies to detect the presence of C. diff antigen. So it's using that immunoassay antibodies to detect C. diff antigen. Does not distinguish active infection from asymptomatic colonization. So just because you have a positive GDH doesn't mean that you have active infection. It just means you have you have some colonization in the colon, or it could be that you have active infection. That's why we do more testing to confirm. If it's negative, though, it's not CDI. If the GDH is negative, it's not CDI. Move on, find another diagnosis. If it's positive, then we're going to do the EIA electroimmunoassay for C. diff toxins A and B. Remember we said that Clostridium causes those 2 toxins. So if the GDH is positive, now let's see if we can find those toxins. And that's the second test. Subsequent testing, if those 2 steps are indeterminate, if they're negative, they're negative. If the GDH is negative, you don't have to pass go, right? It's not CDI. But if GDH is positive and you don't get a full result on the EIA for the toxins, then we can do, for indeterminate results, we'll add the NAT test, which is going to look at the toxinogenic C. diff organisms. It does not, once again, distinguish active from colonization. So understand that algorithm and when you would use which test. But if GDH is negative, you don't have to worry about the other tests. Imaging for CDI, usually only in your severe cases. When we start talking, hey, we're leading towards that fulminant toxic megacolon or a perf of the large intestine. So only severe fulminant disease, we're looking for megacolon or perforation, or if we're thinking they need to get into an OR with the surgeon. That's when we're going to start doing some imaging. You need to know that what we would do to image the large bowel in this case would be a CT of abdomen and the pelvis. If you have positive CDI and then we're moving towards fulminant disease, severe signs and symptoms, going into shock, organ failure, any of those things we mentioned as fulminant disease, it's a CT abdomen and pelvis. You just do an ID with oral contrast. You can use plain films if the CT is not available. They're just an example. These images will not be on your test of the CT or CDI. We will discuss the findings, but these pictures of the CT will not be asked. So the complications, we already mentioned, complications of fulminant disease. You start getting hemodynamic instability, and then you can get some hypercoagulability because we're starting to lose our protein. So we get hypoalbuminemia, which would cause hypercoagulability. Can lead to respiratory multi-system failure, metabolic acidosis, toxic megacolon, and then bowel perf and sepsis. Multi-system shutdown. High mortality rates with anything on that slide, right? Once we get to respiratory failure, metabolic acidosis, toxic megacolon, or bowel perforation, complications from CDI, we're now in high mortality zone. Treatment, well, we're going to admit them if they have any of those complications. What else? What caused it? What caused it? We talked about most likely cause. Our patient was in the hospital, probably, right? What else? Normally, antibiotics. They were on antibiotics. We talked about which antibiotics could always cause or mostly cause, some that could cause or sometimes do, and some that rarely do, but they all can. So our patient was on antibiotics that caused C. diff to overgrow because the antibiotics killed their normal protective microbes in the gut. We stopped that antibiotic because that's what got us there. So we stopped the antibiotic that they were taking that affected the gut microbe. So discontinue the offending antibiotic. Infection control, because we said it can be spread fecal oral, and then also good, clean hygiene practices on all the equipment and anything in that patient room. Got to prevent the spread. But once again, you got to stop the antibiotic that has led us down this road and allowed the C. diff to flourish. We want to give them back fluids and electrolytes, of course. And then we got a couple of first-line antibiotics. I think it's on the next slide, but Fidix, Amosin, and Oral Bank. We'll talk. I think it's on this next slide. Yeah. So mild and severe treatment, preferred regimen is going to be the fidaxomicin, and it tells you there how often, for how long. And then Bank, 125 mg PO/QID times 10 days. If our patients have mild disease only, you can go with metronidazole, 500 milligrams, 3 times a day for a couple of weeks. So fulminant disease. If they have ileus, we're going to treat it one way. If they don't have ileus, we'll treat it another way. So if it's fulminant disease, no ileus, Bank 500 orally or via NG2 every 6 hours, and the metronidazole 500 milligrams IV every 8. So know the dosages and know the routes. If they do have ileus, you do what's in above there as far as without ileus, plus a vancomycin enema, 500 milligrams every 6 hours. So this is a bad thing leading to high morbidity mortality rates. So we're throwing some big guns at them, and we're throwing it often. High risk for disease recurrence if you ever have someone that gets to fulminant disease. Not really sure what that is.
It's fire.
They say test.
For the library.
It's in the library.
Okay. So that's not for us to get out of here. I can't hear anything in here. Just be honest, I can't hear. And I don't have hearing aids on today.
Just wait till you supposed
So as long as we think we're good, okay, driving on. All right, severe disease requires high-dose oral vanc plus IV metronidazole, as we mentioned. Folks that get to fulminant is going to be at high risk for reoccurrence. I'm hoping she's done soon. I'm sorry y'all can't hear me over her. Okay, like I said, I can't hear her at all. So. I'll drive on. Just give me a thumbs down. If it's conflicting, we'll take a break. So who is at high risk recurrence? If they've had fulminant and if they're immunocompromised, so they may have IBD or they could be on dialysis, and then there's a medication that you would give for your high risk for disease recurrence, i.e. they've had fulminant disease and then they're in one of those categories. For whatever reason, they're immunocompromised, they have inflammatory bowel, and they have are on dialysis, and there's the medication that you should know for that. Early surgical consult, yes sir. For them it's prophylactic because they're just at high risk for recurrence because they are in one of those categories. So if you've treated them with what's above it, one of those two, whether it's with English or without, and then you say this patient is in a category for high risk of reoccurrence, then you can add on that next medication. Get the surgeon involved early if someone has fulminant disease. They probably go to the OR. What exactly is she saying?
All clear. Now she's saying all clear.
Okay, we just leave the blocker. Awesome. All right. Recurrence risk. 20% risk of recurrence of CDI. That's any type of CDI, not just fulminant. 20% risk of reoccurrence in about 20% of our patients. If you have multiple reoccurrence, your risk is going higher and higher each time. That's why it's very difficult to manage C. diff or CDI. So risk doubles with each episode. Reoccurrence is 100% if you get a third infection from C. diff. If C. diff gives you a third episode, 100% it will reoccur. Risk factors, prolonged antibiotic use, because we know that's the number one cause. Prolonged hospitalization, we said 20% of hospitalized patients. And then if you have multiple comorbid illnesses, and then also our elderly or our immunocompromised patients. Recurrence has some special treatments, whether it's the first reoccurrence. This is how it is, the nomenclature is documented. Standard practice, not our naming convention, right? Because it gets a little confusing. First reoccurrence is your second episode. So it occurred, now we got a first reoccurrence, so it's your second episode, and it gives you the medications there, and the route, and for how long. Then the second reoccurrence, third episode, now we go to bank for 2 to 3 months. If you get up into that third or greater reoccurrence, meaning more than 4 episodes, then we're going to talk about considering a fecal microbiota transplantation. 90% effective. What are we doing there? We are transferring the microbes and the normal gut flora from a donor patient through a process. It will be given to our C. diff patient. So basically, it's a transplant of the bowel fauna. You're swapping the normal gut microbes in a normal patient for to put it into the bowel of your CDI patient who's had more than 3 occurrences or 4 episodes. And the next slide is going to talk about the process. So basically, you see they take the stool. They want to restore the normal gut microbiome. microbiome. Very effective, like 90%. But you can see there's some options there. They take the donor stool and then they mix and they blend, and they filter, and then they put it in with a colonoscopy or a sigmoidoscopy, or you can get some oral caplets and take it. I don't know if any option sounds great to me, but if you've had 4 episodes of CDI, then this is what we start looking at, a 90% success rate with transferring normal microbiome to our patients' microbiome, resetting their chemicals in their gut, right? Resetting the fault. Very effective and optional. Now we're going to get into toxic megacolon, which is the severe colonic dilation, and you're going to have systemic toxicity from it. Remember, I gave you the measurement earlier. Toxic megacolon, colon diameter typically over 6 centimeters. And you're going to have systemic toxicity. Toxic megacolon is either severe colonic dilation, is defined as severe colonic dilation with systemic toxicity. Like I said, typically it's even 6 centimeters. Acute toxic colitis or toxic colitis, same thing. So you can have the total, or you can have parts of the colon dilated greater than 6 centimeters. It's not obstructive. There's nothing physically obstructing the colon. And it's greater than 6 centimeters, and you've got toxemia. UC, ulcerative colitis, typically can lead to it. May be a complication of Crohn's, but normally also colitis. So inflammatory is going to have Crohn's and ulcerative in it. 2 different types of disease processes under inflammatory bowel disease, which we'll talk about in a full 2-hour lecture. So how do we work up our toxic megacolon? Well, first we got to be able to get that measurement, so they're going to need a radiographic workup, and that is through an abdominopelvic CT with oral and ID contrast, so that the colon can actually be measured. So you've got, for toxic megacolon, you've got this greater than 6 centimeter measured out colon, and then fever, tachycardia, leukocytosis, hypotension. So our patient is crumping, right? And here's the workup there on the left. Diagnostic criteria. You got to have that dilation of the radiographs measured out, plus that fever, tachycardia, leukocytosis, and some hypertension. And it gives you the cutoff scores or measurements for the fever, the tachycardia, and the leukocytosis, and anemia. So you got to have radiographic evidence greater than 6 centimeters, and then at least 3 of the next group, fever, pulse, leukocytosis, or anemia. So at least 3 of those with 6 centimeter dilation, and 1 at least from the final list on your slide, either dehydration, altered mental status, electrolyte disturbance when you draw the chem panel, or hypertension. So know the diagnostic criteria for toxic megacolon. And here's where we're just doing that abdominal pelvic CT. This will not have a CT of toxic megacolon on your exam, not the picture. How do we treat it? Well, we got to get rid of some of that colonic distension. So we put them on bowel arrest and stop them from eating. Give them some fluids, and if we can figure out the underlying cause, we treat that. But normally that's going to be with a phone call to the surgeon on call. So basically put them on bowel arrest, they're eating nothing. Give them some fluids, get those electrolytes that you drew in the labs straightened out. If it's C. diff, we can treat it. If we think it's an inflammatory disease, or inflammatory bowel problem, we can give them some glucocorticoids. But normally, for toxic medical colon, it's a pretty early call to the surgeon. So this is just the layout there in the little cartoon of C. diff and its process. So now we're moving into diverticular disease. Pretty much looks like what you see there on the tire, that protrusion, bubble that is happening in your large intestine. It's a small pouch protruding from the colon wall, just like the tire looked. The pouch of the rubber on the tire. They get there from increased intraluminal pressure, so pressure inside the lumen of the large intestine increases, and then you get a little pop out, right? A pouch protruding from the wall, exteriorly, on the outside. So there is a difference between just having those protrusions and them being inflamed. So when we add itis to it, it's going to look different from diverticulosis, which our elderly female on the test today just had diverticulosis, large volume, painless GI bleed. If she had diverticulitis, it's going to look very different. Just some studies showing it. Once again, these will not be on your exam as far as a colonoscopy or a baronema showing the little out pouches, but you've got the positive arrow signs.
May I have your attention, please? 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 We are conducting a test of the fire alarm mass notification systems. This is only a test. You will be notified when the testing is complete. Do not evacuate the building.
I could hear that.
May I have your attention, please? May I have your attention, please? May I have your attention, please? May I have your...
Hey, just go ahead and take Sam.
All clear. All clear. The emergency situation has been resolved. Please return to your normal activities. All clear. All clear. The emergency situation has been resolved. Please return to your normal activities. All clear. All clear. The emergency situation has been resolved. Please return to your normal activities. All clear. All clear. The emergency situation has been resolved. Please return to your normal activities. All clear. All clear. The emergency situation has been resolved. Please return to your normal activities. All clear. All clear. The emergency situation has been resolved. Please return to your normal activities. All clear. All clear. The emergency situation has been resolved. Please return to your normal activities. All clear. All clear. The emergency situation has been resolved. Please return to your normal activities. All clear. All clear. The emergency situation has been resolved. Please return to your normal activities. All clear. All clear. The emergency situation has been resolved. Please return to your normal activities.
They have lots of relatives? How much? Well, they don't have a fire back there. I guess there's 8 or playing on them. Yeah.
Yeah, but then for the initial.
That's 47 years overdue. We're going to execute on that regardless of what you say about it. Yeah, right here.
Well, maybe I am. Pretty awesome. I didn't have that.
Graduated senior year.
Oh, that's like, that's, so we still have a month and a half. So it's like, month-ish.
Sorry?
They live in an empty house. That's a
So I
long
wrote it
month.
all down.
That's still way more than.
That's what I'm saying.
Yeah,
Like,
that's still way more than. Let's go have more than 21 days to back to
they only allow you to count.
And also, like, 21 days and your PCSing comes. It's 7 days of comes. Yeah, so you have 7 days. Okay.
I think I had 7 days, and then like, I think it was total was like 14 days, because like I added the that's like extra days.
How's that?
Yeah.
No, that's
It's still
Yeah, I made it 96. I talked myself out of it. So I was like, he's trying to say that they're compromised, but he was doing a separate auto, so I'm just going to pick the other one I did root to
Yeah.
So I was like, oh, it's a selection. I shouldn't pay attention. That was only like
Wait, you're talking about your friend, the one, the senior, or the one that graduated?
I'll tell you what, guys.
I thought he said he was a student. Yeah. That's good for him. He'll be another.
Oh, here it is. Do this, do like check it, and then do
Yeah.
I was like, that big flame is coming out.
Yeah, right. That kid.
I'm sure.
That seems like a I don't like brand.
One to go.
Yeah, just like it's like -5. Like shot like 5 or 6 under on the front. Just like just having like one of those rounds.
Why do you have to have
Rory's playing. I guess Connor. That's a hard. This guy's back at it again.
Wait, we started at 10:23. So we have 2
Yeah, like you like person and then whatever, and then that's the final pairing with. It was like him, and then there was like a veteran, Shane Lowry.
Oh, you obsessed with Shane
And then Shane Lowry like, no, double bogeys, right?
Yeah, she might have changed it up on this. Remember how it caught him? Or maybe she just like that.
That is like He was like
I guess.
-16. The last 3 holes, double. I think he did to get it. He was fast for a possible chip in to tie.
Yeah.
Like the first time I go off with my wife.
I think they started
Nothing.
or something. I think next week happens.
The golf course. I was far. I was having
I remember it was like, just like one of the
I shanked it off into another.
What did I take for ophthalmology? I'm just saying anything IT off.
She was like, just punch out. She was like, trying to give me advice. I went through the woods. Like, I was like, I'm going through. You see that little gap right there? I just chucked it like 3 times. And I was like, oh. Still probably didn't the first time
You were.
yeah.
Okay, so for colonic diverticula, most are asymptomatic. They vary in size and number. Usually it's in the sigmoid and descending colon. Almost universally, that's 3 to 5. Like I said, how do we get them? That's the increase in luminal pressure, low fiber diets, and being chronically dehydrated. Those are your big 2 causes. So diverticulosis simply means there are diverticula. So if you have diverticula, you have diverticulosis. Incidentally found often, unless you get that patient like we had on the test, or we discussed when we get our elderly patient with or an adult patient, any adult patient with a large volume bloody stools, no other signs and symptoms, we usually think diverticular bleed. Usually asymptomatic, if anything, it's that bleed. Really don't have to do a treatment or workup. Basically correct the cause, which is get them on a high fiber diet, introduce it slowly, get them on a fiber diet, a fiber-rich diet, and get them hydrated. You do not, with diverticulosis, need to worry about their diet of seeds, nuts, popcorns. You don't have to worry about telling them to stay away from that if they have diverticula. The risk of those things getting stuck in a diverticula and causing a diverticulitis is really low. So, with just diverticular disease, find it incidentally, drink more water, increase your fiber intake, but you don't have to worry about avoiding anything like the seeds or nuts or popcorn that would cause an inflammation or a blockage in the diverticula itself. Diverticular bleed, painless, bright red bleeding from the rectum. Bright red, large volume, which is different than our normal anal rectal bleeds from internal hemorrhoids or external hemorrhoids or fissure. Those are usually bright red, but low volume. Low volume. For diverticular bleeds, usually self-limited, painless, often under pressure, so the patient may say, hey, I have blood squirting into the toilet when I defecate. Usually no other symptoms. If they are actively bleeding, what do we say for all our GI bleeds? Sick, not sick. I think 100% of you got that right on today's test. So we have to stabilize our patient first and say sick, not sick. If sick, not sick, get them stabilized. If need be, then start worrying about treating the underlying cause. If they are bleeding, once they're stable, we're going to do endoscopy. And for diverticular disease, it's going to be going bottom up, right? Because we're not thinking this is an upper GI bleed, so we're going to go colonoscopy or flex sig. If they don't have an active bleed, but they have a history of bleeding, or you suspect they have diverticular disease, then you can refer them out routinely for a scope to make the diagnosis by looking and seeing. But if they're actively bleeding when they come in to see you, they probably need to go to the ER, stabilize them, and then do a scope and see if we can find why they're bleeding time now, and then cause some hemostasis. Versus if they have a history of it, then we need to refer them for a scope if they're not actively bleeding when we encounter the patient. So 2 types of diverticulitis, uncomplicated and complicated. Uncomplicated, just local. Local inflammation of colonic diverticula. You can have micro preparations that are contained, and you can, at that point, you don't have any kind of systemic response because it's contained right to the diverticula that gets inflamed. Uncomplicated. No systemic responses. If it's complicated, now we're going to get inflammation of the colonic diverticula. So we start worrying about the complications such as perf, bleeding or continued bleeding, and obstruction, fistula, phlegmon, or an abscess. And we've talked enough about each of those words that you should have a good handle on what they are at this point. Any of those, now we're moving towards complicated diverticulitis. An inflammation or infection of the diverticula that before were asymptomatic. Usually abdominal pain and tenderness in left lower quadrant versus diverticulosis, normally no associated signs or symptoms. Patient has an inflammation, an infection, so they're going to have a fever, nausea, and vomiting. So classic presentation would be left lower quadrant, abdominal pain, fever, and nausea. Physical exam, as I said, left lower quadrant, tender palpation. 20% or so, you can actually feel a mass in the left lower quadrant. The patient's going to have a fever. And if we're starting to see those peritoneal signs, now we're worried about the complication. Things are perfing, things are getting systemic, septic. Lab findings for diverticulitis, you're going to have some increased white blood cells of the CBC, and may or may not see some occult blood in the stool when you do your fecal occult blood test with a DRE. Diagnostic imaging, CT scans preferred. Do not do a flex sig or C-scope on an active diverticulitis, because you can make it worse. You aggravate the inflammation, or you might just perf the bowel, and now you have an emergency surgery that was caused by something you did, because standard of care is do not do an endoscopy, either a flexing or a C-scope for an active diverticulitis. CT preferred, CT of abdomen and pelvis. If it's mild disease, may not have to run right to the CT. If it's just mild TTP and no fever. If they have those symptoms, get them in the scanner, and get the diagnosis. But don't scope them. How do we treat it? Mild, conservative, outpatient. Liquid diet, see them again in about 3 days, make sure they're coming along. After their acute diverticulitis resolves in a couple of months, 6 to 8 weeks, then we refer them for the scope. Not before then. If we are treating them outpatient on liquid diet, looking at them, making sure they aren't developing fever, or if their fever is not subsiding, then after that second or third day, then we need to be admitted into the hospital. So if they have no improvement, you tell them to follow back up in 2 to 3 days, or their pain's getting worse, or they develop a fever, or worsening fever, or if they can't take oral fluids on that checkup, then it's time to get them admitted. So when do we have to absolutely admit to the hospital? Those are your criteria for inpatient management, and you should know those. So if you have complicated diverticulitis on CT scan, or you have uncomplicated with any of those listed, sepsis, severe abdominal pain, you're elderly over 70, fever's above 102 Fahrenheit, if you're immunocompromised, significant comorbidities, are unable to take oral fluids, or if you've failed the 48 to 72 hour rest, take it easy, increase your fluids, then it's time to get an inpatient treatment. And then a couple of slides back, you can go back and review for what makes an diverticulitis complicated on the CT. Severe disease, yes, they're in the hospital, right? Broad spectrum antibiotics. So this is your patient that you admit and give them IV broad spectrum antibiotics for their diverticulitis, and then after 3 days, they develop CDI, right? Because you're giving them broad spectrum based antibiotics, and you're going to continue that until the inflammation is stabilized, and then you're going to transition to oral. So this is how those folks end up with CDI. They get inpatient long-term broad-spectrum antibiotics. Also with our inpatient, we're going to give them IV fluid and electrolyte replacement. We're going to give some pain management, left lower quadrant pain. If you're thinking it's severely, or there's a complication, we're thinking a perf or an ileus, things aren't moving through the bowel, then we're going to get a surgeon involved. Then when they're discharged, you give them another 2 weeks of antibiotics. Those are the complications: perfs, abscess, fistula, obstruction, all the same things we could get in the small intestine that we discussed last block. If your broad-based antibiotics are not improving your patient's symptomatology or presentation, then consider that there's a complication. Get a CT scan. If they're showing any signs of potential complications or not responding to the broad-based antibiotics. If they're not getting better on your antibiotic regimen once they're admitted, not able to move them towards PO antibiotics, and then discharge them with 10 to 14 days worth of antibiotics, then go ahead and get the scan because you're looking for those potential complications on the top of the slide. Okay, new topic. That's what we have for diverticulosis and diverticulitis. So now we're going to talk about acute colonic pseudoobstruction. Functional obstruction of the colon. No physical blockage. It sounds a lot like something we discussed in small bowel disease, right? So it's functional obstruction, not of the colon. There's nothing, no physical blockage happening in the large intestine itself. So that Ogilvie syndrome, that's just another name for acute colonic pseudoobstruction. So it's the signs and symptoms of an obstruction. Things aren't moving through there. We'll talk about the specific signs and symptoms, which sound a lot like a small bowel obstruction as well. But for the acute colonic pseudoobstruction, you don't find any lesions, but you have those signs and symptoms of obstruction. Usually this is in the cecum or the proximal colon. Basically, acute paralytic ileus of the colon. If you think of it as acute paralytic ileus of the colon, that's what acute colonic pseudoobstruction is. It equals acute paralytic ileus of the small intestine. We will see presence of bowel dilation on imaging. So you don't have peristalsis. There's, for whatever reason, peristalsis is not happening in your large intestine, but there's nothing blocking the intestine. Usually, once again, your hospitalized patients. Post-surgical, kind of still sounds like your small bowel obstruction, right? Or your idiopathic paralytic ileus. Post-surgical, 3 to 5 days, we're starting to worry about acute colonic pseudoobstruction. Trauma can cause it. And then your medical inpatients, respiratory failure, MI, CHF, so bad comorbidities in your patients who's hospitalized can lead to acute colonic pseudoobstruction. Signs and symptoms: abdominal distension, mild pain, obstipation. Everybody remember what obstipation is, right? So what do? First, we rule out a mechanical cause of a pseudoobstruction. If we find a mechanical obstruction or mechanical cause for the obstruction on the CT, it's no longer a pseudoobstruction. We have a new diagnosis. If find a mechanical cause. If not, it's functional acute colonic pseudo-obstruction. CT is the study of choice, and as I said, that's to rule out actual mechanical cause. How do we manage it? Bowel decompression. Nasogastric tube again. We also go with bottom up or rectal tube decompression, not just ENG tube. Figure out the underlying illness and treat that. And if you're on drugs that reduce intestinal mobility, which your post-op patients are probably on, opioids, we try to get them off that. Because that can be, the opioid medicines can be reducing intestinal mobility and contributing to the pseudo-obstruction. So we decompress the bowel, discontinue any opioids or any other medicines that halt intestinal motility or peristalsis, and then we try to treat the underlying disease, and once again, call our friend on call, the surgeon. Next topic is a sigmoid volvulus. No longer a pseudo-obstruction because something mechanical is happening in a sigmoid volvulus. The bowel is actually twisting in on itself, causing an obstruction. Just like a balloon, pull it, twist it, we've got an obstruction where there's twisting of the sigmoid, normally the sigmoid colon. So that is called a volvulus when you have that torsion. And obviously there's an obstruction because where it's torted or distorted, then you don't have normal peristalsis through that compressed and distorted portion of the large intestine. Usually sigmoid colon, that's why it's called sigmoid volvulus. You can have volvulus anywhere in the large intestine, but normally it's sigmoid. If it's not in sigmoid, then it's not sigmoid volvulus, it's just volvulus. Our signs and symptoms of this mechanical obstruction now, right? Progressive, insidious onset, progressive abdominal pain. Then it's going to get continuous and severe. Severe abdominal pain. Once again, constipation, obstipation. So it's sounding a lot like our small bowel obstruction, whereas the pseudo sounded like our paralytic ileus. Kind of the same concept, different part of the bowel, or different part of the GI tract. The patient's nauseous, they have abdominal distension, they have vomiting because they have mechanical obstruction, and the products of digestion are not moving through their large intestine. And if the sigmoid volvulus, they're getting down to the sigmoid colon and not passing go at that point where there's a volvulus or twisting of the large intestine. Physical exam for sigmoid volvulus. Distended abdomen, but there's no tympany to percussion, and there's tenderness to palpation. You need a CT. You need a CT to confirm. And remember, in the pseudo obstruction, we get the CT. And when we get the CT, we might see that sigmoid volvulus to confirm there's actually a mechanical cause. It's a sigmoid volvulus. And now we can fix this potentially. Usually the labs are unremarkable in early disease. To diagnose the sigmoid volvulus, we need a CT. And then usually they untwist the twisted portion of the sigmoid colon with a flexible sigmoid scope. So just detorsion. Using the scope to try to get it opened back up, untwisted on itself. That brings us to the memory jog for large intestine. We're going to talk about some more large intestine pathologies when we get into the inflammatory bowel disease processes, ulcerative Crohn's, and a few others. But that's all I'm going to give you guys today for GI, and then we'll start back.